So this is my new center. It's been a year now working in my new center. Rhinoplasty comprises of almost 25% of our entire surgical load. Last year we did close to 100 rhinoplasties, and mainly I do aesthetic rhinoplasty. Not moving. What happened? So, when you look at the variations in aesthetic, it's all about the tip and the dorsal contour. So, patients nowadays, we are exposed to all kinds of geographic locations. So, we have at my place, you have influence of Korean cinemas. Girls and boys are looking at Korean cinemas. So, they have different sets of their aesthetic proportions. And then we have like a standard Caucasian population from the rest of the part of the Assam, especially in the lower Assam, we've got Caucasian population predominantly. So there again we have Western Hollywood movies, Indian movies. So the influence is now it's combining in. So there are differences, there are different demands by the patient when we talk about aesthetic rhinoplasty. So if you see here now, these are again both different patients, different kinds of nose. So here, if you look at this girl here, so if you look at this girl here, she has a bit more, the dorsal curve is a bit more exaggerated. Her tip angle is slightly more higher.
The
so
cursor is not working.
Sujana,
the cursor.
Okay, this one I have, yeah. So, but you can see here, all the anatomy has been taken care of anyway. So here you have this girl on this side has a more curve in her dorsal contour. Her tip is slightly more exaggerated because she wanted this kind of, she's an actress, local actress, so she wanted a more highlighted tip, especially the tip she wanted. And then we have one more girl here who's, if you see the after part, she's got a bit more, subtle changes on her dorsal bridge. I've concentrated more on the radix, then kept her dorsal more or less straight, and also I've given her a very subtle supratip breakpoint. So supratip breakpoint is a very important part when you look for an aesthetic rhinoplasty point of view. So you see here, this 10 millimeters above the nasal tip is your supratip breakpoint. So this is very important. So these are again two different kind of variations that you're looking at for aesthetic rhinoplasty. Then you've got a very conservative nose bridge. It's more or less straight. It's very similar. Now, this girl has very good nose. It's a good nose, but she's just concerned about her droopy, that her tip is slightly more masculine. That's what she said. It looks like a male's nose. So we went on with slightly more, like keeping the nasolabial angle around about 95 degrees, but we've kept her bridge much more straight. Now on the other hand, we have one more patient. So she is an influencer. She makes a lot of videos and Western style of videos. So she was very specific. I want Barbie button nose. So nowadays, this is the more common demand, button nose, Barbie nose. So again, so here if you see, it's a bit more exaggerated. The tip is more, it's slightly distorted, the image actually. But she's got a more tip going up. The angle is slightly more exaggerated. Her supratip breakpoint has been exaggerated a bit more compared to say this part. This part, like supratip breakpoint, is very minimal. Here is a bit more exaggerated.
Explain the supratip break exactly more.
So supratip breakpoint, if you see here, I think I'll have to come here. So you see, this is the nose tip. Okay, so this is the nose tip. Your columella, your subnasal, this is the nose tip, and the point where the nose the dorsal meets, this curve here, the tip here as the point. So this is your supratip breakpoint. So it's very essential when you're talking about aesthetic rhinoplasty that you have to consider the supratip breakpoint. Even in the nose where the supratip breakpoint not very prominent, but see the supratip breakpoint is still lower than the tip. So it has to always remain lower than the nasal tip. If it goes higher, you'll end up with a polybeak deformity. Okay, and your nose will not look good enough. Now again, considering male rhinoplasty, again males, we tend to keep the nasolabial angle close to 90 degrees. So we have to maintain that 90 degrees of nasolabial angle. So for male, you want a long, more strong projected nose. But some people would want a bit more tip getting highlighted. So you see here, my supratip breakpoint is slightly more exaggerated. It's still about close to 90 degree angle nasolabial angle, but the tip supratip is slightly exaggerated. So his specific demand was, he sent me a picture of Enrico Iglesias, that singer in 90s, one of my favorite singers. So he actually showed me his picture. I want nose like this. So he's got a very prominent, nose tip and a supratip breakpoint. So that is where you have to again see. So that's why I keep insisting. Suppurative Brakeman is very essential when you're looking at an aesthetic rhinoplasty. Overall aesthetic, I will not go into much because everyone's talked. Dr. Gaurav has spoken about it. So I will not go to assessment part. It's already been done. But according to I always look at the radix, dorsal, keystone area, followed by suppurative breakpoint. Then you've got nasal tip, subnasal, nasal label angle, columella show, 2 to 4 columella. Columella show should be restricted to 2 to 4 millimeters, not less than that, not more than that. Okay. And frontal marking, I generally see how the bridge is falling, how the contours are, how much parallel are the nasal bridges. Okay. And then I see the alar, how it should fall within 2 to 3 millimeters from parallel lines drawn from the medial canthus, both sides. So it should not be too much constricted. It looks very artificial. Should not be too much out, should not be like more than 2 to 3 millimeters outwards towards this line. It will give you a wide nose appearance. So, but it should not be too constricted. Narrow nose doesn't mean a good nose. It has to be a balanced nose. Okay. Now, from the worm's eye view, what I look at is that these 3 lines. So I divide the nose into 3 equal lines. So the nasal lobule should form around about 1/3 of the total height of your nose, and it should be an equidistant triangle. So equidistant triangle, proper nose. So you don't necessarily have to do an alaplasty every time. Okay, a lot of time when you project a nose tip, it automatically the side of the skin, the alar skin gets stretched out and it becomes more narrow. Now, aesthetic rhinoplasty, you have to have closed rhinoplasty into your armamentarium. It's not that open rhinoplasty has scars. The inverted V incision that Dr. Gaurav showed, it has fantastic healing. There are hardly any scars. We've not had a patient complain about scars with an open rhinoplasty. But this is there, social media is there, it's bound to happen. People are bound to ask you, can you do closed rhinoplasty? So what my suggestion is that closed rhinoplasty, when you do, you have to first get accustomed with the open rhinoplasty. So here you see I give marginal incision, just like how Dr. Gaurav showed, that marginal incision along the columella, so that we have done. Now I give marginal incision along the lateral crura, that's the alar, the lateral part of the alar cartilages. And I use a Cottl's elevator. So I feel very comfortable with Cottle instead of scissors. So every surgeon has their own way of doing surgery. I'm comfortable with Cottle more because I go subpericondal. So that's my preferred plane, because as I told you from beginning, it's the beginning of the day, that I don't like to have blood in my field. So I keep it as bloodless as I can be. So if I go subpericondal, I can stay more clean and bloodless. So you don't encounter much blood. When you don't encounter much blood, you see your cartilages very clearly, then you can work on your cartilages much more better. Your markings will be very clear, and when you finally end up your surgery, it's again very clear. So the technique is same, like how Dr. Gaurav showed, that same thing, marginal, both sides, connected, protect the intermediate crura, and then incise and open the nose. So you see here, so I go subpericondal, but you can go both ways. You can go suprapericondal, you can go subpericondal. It depends on your comfort level, how you want to approach and what is your comfort level of approaching. Once I've done, so I'm showing closed rhinoplasty here, okay, as a variation for aesthetic rhinoplasty. Once I'm done, I'm through this Pitangui ligament. So this is the Pitangui window. So that's Pitangui ligament is a ligament which passes all the way from the nasal spine. It attaches the cephalic end of your medial crura and the caudal end of your nasal septum. It goes all the way up to the intermediate crura. From there, it goes into the skin at the supratip breakpoint. So that is what is holding. So you have to create. So that's the window between. So I'm going through the Pitangui ligament, that Pitangui window, to create my window. So once I'm done with this part, then comes my septal extension. As mentioned by Dr. Gaurav, it's very important that you stay subpericondal. So in closed rhinoplasty, now you see how it's happening, that I'm retracting my tissues towards one side and I'm working from one nasal opening. So closed rhinoplasty, this is the only difference. Okay, in open rhinoplasty, you just straight, if you open it, in here you use additional retraction to move it out. You can actually get both the cartilages out from one nasal opening, and you can see here again, I'm going now that fanning motion, like how Dr. Gaurav had mentioned, that fanning motion. So this is where I'm doing that fanning motion. See, my instrument, I'm not pushing. This is the fanning motion. So I'll go up and down till I find my pericardium. So that's the pericardium. You see that white tissue on the other side, which I'm holding with the instrument. So that is the pericardium. So here you see, now I don't find any restriction. Once you subpericondal, nasal septum, your instrument will just glide through until and unless you have some problems like previous surgery or maybe some severe septal infection. Only then you'll find scarring. But otherwise, it just glides through. So if you're subpericondal, there's very few chance of you perforating, but you have to be careful of the curvatures of your cartilage. So you don't push your instrument. If you're pushing your instrument, that means you're not in the right plane. If you have to push, that means you're in the wrong plane. Okay. Once I've done this, then I use again my cochlear elevator to elevate all the tissues. So now I'm going into the upper lateral cartilage. Then from there, I'll be going down into the nasal bone, into the lateral nasal wall. So this is how I again go. See, I am at the subpericondal and subperiosteal level. Again, to avoid bleeding, to minimize the bleeding. The less bleeding, less use of cautery, less damage to the tissues. So this is how I go. You keep following the anatomy. It's very similar to closed rhinoplasty. The only thing is you've not opened it from one side. So once I'm done this, then cephalic trimming is the next part. Here again, if you see this, you have to be careful. It has happened with my fellow when I gave a free hand. So they were a little deep and they ended up cutting through the mucosa into the skin. So whatever skin you see below is basically the nasal mucosa. It's a very thin mucosa. So if you're not careful, you can easily cut through and reach the nasal mucosa. So you see here, so it's easily coming out. So here again, you have to stay just below the cartilage so that there's again no bleeding. It's a clean feel. You maintain a clean feel. Again and again, I keep emphasizing that you have to maintain your surgical planes. Once you've done this is an important slide which I show to everyone, like how your nose generally is before the surgery. So this is, you see here, so this is your medial crura, your intermediate crura, your lateral crura, and that's your upper lateral cartilages. So you're not intending to change how your structures look like at the time of your rhinoplasty. What you're looking at, get it closer to the ideal proportion. So you see here, I've brought lateral crura anteriorly so that it removes the bulk from the nasal bridge. I've got the tip up. I've maintained a good open angle at the intermediate crura. I've supported the nasal cartilages so that it gives you a much better projection. So all now it depends on how you are planning. You want upturned nose, you want straight nose. So it depends on the angle where you're going to put your intermediate crura. Next is the resting angle. Now this is very important, which I keep in mind in all my surgeries. The resting angle between your lateral crura, okay, and the upper lateral crura. So this is the lower lateral crura, that is the posterior part, and this is the upper lateral crura. So here I try to maintain an angle of 90 to 110 degrees. Because when you maintain that particular 90 to 110 degrees, you're moving your alar cartilage, the lateral part, anteriorly. So automatically you're moving all the bulk from your nasal bridge. So you have a much more nice and sharper nasal bridge. So that's very important. Okay. Here you see I maintain minimum 8 to 10 millimeters of the width between the intermediate crura, and you can see both are different rhinoplasties, but they look similar. They all look similar. Here also, treatment planning. Here I'll do radix augmentation. I will not reduce the nasal bridge, so that I will keep in mind. So for radix augmentation, temporal fascia is very good, but sometimes you can use excess septal cartilage also, which you harvested. Okay, so you can see here, this is 10 days post-op. You've got a nice bridge, you've got a nice contour, parallel. It's not very narrow nose, it's parallel walls. So nasal walls have to be parallel to get a good view. Septal cartilage, as Dr. Gaurav mentioned, we used the septal cartilage. So trimming, I always maintain minimum 5 millimeters because that's my aim, to have 10 millimeters of open angle into intermediate crura. So I maintain 5 millimeters. Lateral crura, I maintain about 7 to 6 millimeters every case. Okay, and this is how normally I support it. And you can see here also, different cases, again, same how it looks around about 110 degrees. So I'm maintaining 90 to 110 degrees. Always strengthened, like how Dr. Gaurav, he put that extra cartilage on the caudal septum to strengthen it. Indian septums are notorious, they're weak. They're less than 1 millimeters most of the time. So you have to strengthen the caudal septum by additional cartilage being stitched to it. Okay, so internal valve angle, again, that 90 to 110 degrees. Everywhere you will see me doing the same thing. Again, this type of case where the radix is normal, there's a hump. So I'll be addressing the hump. So you have to be careful when you address hump. Removing a hump and then closing it is the wrong way because you have an open valve. See, So now when you do an osteotomy here, this is the cartilage part will tend to collapse. So then you get an inverted V deformity. So it's very important that in all your surgeries to have to put spreader graft, so not to have internal walls collapse in your surgeries. So you see here again, same thing. I've left an open angle in this case also. Okay. Sometimes I use cap graft, sometimes I use shield graft if I need additional projection of my nose tip. Augmentation rhinoplasty, we do two types. One is Diced cartilage fascia, which is a more easy technique, but it has a longer recovery. It's a bit unpredictable, okay, because of the resorption of the graft and the potential of resorbing. So you have to be very specific not to crush the cartilages, and you have to, cut the, not crush. You have to actually cut it like a vegetable in less than 1 millimeter each particle. So you do that, then I use temporalis fascia, minimum 3.5 to 5 centimeter in length. I do perforation so that there is neovascularization. You don't want a dead cartilage there. You want a living live cartilage so that it stays there. Resorption is less. So I do multiple perforations for neovascularization. The other technique is push-up technique. Now this technique is used by very few surgeons do it. My center is one of the few centers we actually do push-up techniques. So here we don't put a graft on top. So what we do is we osteotomize the nasal bridge. So you see here, so the entire nasal bridge has been osteotomized. The cartilage has been pushed in between the vomer and ethmoid and the bone on the top. So you're pushing the bony bridge upwards and wedging the cartilage in between. So this is more predictable because it is not going to resorb. It's going to stay there. And you can see here, you don't see the cartilage. See, the upper laterals are intact. I have not cut the upper laterals. I just cut a little bit to just visualize my show. And the whole cartilage is inside, lifting the bone up. And also small incisions, very small incisions for your rib because these are aesthetic patients. They are not, pathological patients or something like that. So this is just a short video to make you understand what is push-up rhinoplasty. So you see, I'm wedging the cartilage inside, below the upper lateral cartilages, above the nasal septum and the vomer and the ethmoid posteriorly. So that is where it is sitting up, and then it is being stabilized with the septal extension graft on the center. So you see, end of the day, all different noses, but they all look the same. Same angles, open angles, everything is same. The technique is very similar. The only thing that differentiates is that what height you're going to plan for surgeries. Thank you.
Listen, एक सवाल है. Listen, so you mentioned about supratip and columella show. So what I'm asking is, how do you surgically manage that supratip break at 10 millimeters? And second thing is, how do you?
So what I do is I basically at the end of my surgery before the closure, so I drape and I see where all my skin is not adapting. So there's a beautiful article. I'll put it on the camera. I'll send it to ma'am. So there's an article of skin sutures in nasal rhinoplasty. How do you do skin sutures? So there basically what I do is, I told you about the Pitangui ligament, right? It runs all the way from the nasal spine up to the skin. So that is what is called the supratip breakpoint. So I engage that ligament again. So I normally mark it or maybe put a suture and preserve the Pitangui ligament there. And then again, yes. So you mark it or you put it, or sometimes I put a needle and just I see where it is. Then I take that the bite with a PDS and again I bite it back with my columnar cut or maybe a septal extension graft and bring it down in. So that is how I maintain. I reconstruct the Pitangui. So it's called as Pitangui reconstruction. So that if you do, your supratip will come up here.
Okay, and now you mentioned that your columnar show has to be exactly 2 to 4 millimeters. Yeah? Okay, so what I was asking you is basically, now if you are putting a graft, a columnar cell graft, can you manage to see that it is exactly kind of
No, we'll discuss this later.